little bit different. Um, I have some really strong personal feelings about substance use and diagnostic procedures, and I'm going to suspend my own commentary on a lot of that. But what I want to just point out this week is the fact that, first of all, most times substance use diagnosing requires a substance use professional, and this has to do with insurance and sort of the medicalization of this as a particular class of disorders. And so for this particular slide deck this week, I'm not going to go into a lot of the DSM specific detail because there's a whole lot there. First of all. Second of all, we're not always going to be the folks that are in charge of creating and establishing initial substance use diagnoses. And third, I think more importantly for us as clinicians, as both clinical mental health counselors and school counselors, is how do we help? How do we work with people who have issues related to the use of substances? And so just as quick a quick overview of the diagnostic process, substance use disorders typically are going to be recorded using the specific code that applies to the class of the substance. And then you want to name the specific substance. And so there's a number of particular symptom categories or symptom clusters that you might see with a substance use disorder, and I have those listed here, as well as different specifiers. And so, for example, a substance use disorder diagnosis could be alcohol use disorder, mild, or it could be cocaine use disorder, severe, those sorts of things. Anyway, again, take a look at the DSM and certainly kind of play around in the chapters, but also realize and recognize that we're often not going to be the folks that are making these primary diagnoses. A couple of other important sort of conceptual pieces is the sort of differentiation between different stages of substance use, and so substance intoxication versus substance withdrawal. Both of these are different sort of time periods during the addictive process, and so intoxication you're going to see happen after recent use of a substance. Sometimes there will be clinically significant problematic behavior or changes, and then also important to note that those behavioral and psychological changes can be different depending upon the substance, and the signs and symptoms of substance use can also vary. As opposed to intoxication, substance withdrawal usually happens at the cessation of drug use, and so this is what happens when a person is coming down from a particular drug. A number of different classes of drugs are included, and each of those, what these have in common is that each has an impact on the brain reward system. And so all of the literature points to the use of substances in the individual as a way to stimulate activation in neurotransmitters and brain reward systems. Since there are so many different classes of substances, I figured I would choose just one and point out a couple of things about alcohol abuse. And so I like this particular schematic because I think it really gives a good picture of kind of the process of how alcohol impacts the brain. And so you see here in this image, the first step is sort of alcohol impacting the forebrain, motor coordination, decision making, those sorts of things, and then alcohol will go after the midbrain, and that's where you might be a weepy drunk. You might lose control over your emotions. There might be an increased chance of a blackout, and then if you continue to use, then the last stage would be stage 3, where alcohol is really impacting the brainstem, and this is whenever it's going to impact your heart rate, body temperature, those sorts of things. So more of the autonomic aspects. So this is what happens on a night of drinking. Over time, the long-term impact of alcohol abuse, you're going to see potential for impact in lots of different body systems. So certainly the brain, even the esophagus, lungs, liver, heart, etc. You can see here on this particular slide. So it shows kind of a good overview of the different areas of potential harm that can come from a long-term use of alcohol. So then how do we help, right? I think that, like I mentioned, we're not necessarily going to be the ones that are initially diagnosing substance use disorders, but we are likely to see substance use specifically. Well, I'm not going to say that. I think both clinical and school counselors may come across um, individuals that are struggling with substance use. And so I think prevention, you can really think about this as sort of at the front end of substance use. And so this is usually during early stages, maybe the intoxication stage, really trying to help individuals understand what's going on in their body when they use drugs and alcohol, those sorts of things, but also what are some of the other impacts. And so this can look a lot of different ways. I think how I typically approach this in my practice as a clinical mental health counselor, my very first strategy really is to obliterate shame. Just get rid of shame with regard to the use of substances. Personally, I believe that everything we do to mitigate the pain of trauma is a strategy for survival, and that includes using substances and alcohol. And so I want to meet my clients there. I want my clients to hear me say that I appreciate the lengths to which they have been willing to go to keep themselves safe and alive on the planet. And it's really unfortunate that because of how substances impact the brain reward system and because of the immediate sort of replacement of those attachment feelings, that this is like a really sneaky strategy. And it's not sneaky from the sense that the individual is being sneaky, but sneaky from the sense that the use of substances over time helps, and that's why it's such a big deal. And there's also the concept of diminishing returns, which I believe is originally like from economic theory, but the idea is that over time, the drugs are not gonna help as much. There's gonna take more of them. The individuals are not going to experience as much pleasure or satisfaction. However, the brain's already been tricked, right? And so there's already this sort of compulsion toward using this substance to hope for that initial sense of euphoria. There's a sweet little video that I've included in your shell about just a kind of a cartoon sort of thing that I think shows a really good depiction of what this looks like. And so back to my slide here. So prevention, usually early on, you're going to have some psychoeducation. Family therapy might be another important potential intervention or prevention strategy. And then also really understanding what's going on in the social environment. I think that the loss of self that happens whenever young kiddos are experiencing chronic stress and abuse, the loss of self was really the essence of trauma. And what happens whenever we use medication, whenever we use substances, is that those dopamine reward centers are activated, and so that is the sensation of finding self. And so it makes sense, sort of conceptually to me, that using substances is an attempt to reconnect, when in fact probably the opposite is true. So over time, back to kind of the clinical picture, intervention and treatment. A couple of things here, and I think these are all sort of couched under the umbrella or the lens of shame. And so the first point I make here is that don't assume clients are going to be honest with you about their drug use. because there is so much shame and stigma associated with substance use. Many times clients will underreport, and I understand that. I was a smoker for years and years and years. I started smoking when I was about 14, and I didn't quit until, oh, let's see, about 15 years ago now. So I would have been, I don't know, how old was I 15 years ago? Mid 30s. So I smoked for a good part of my life. And I know firsthand that I often would not be honest with how much I was smoking. And the reason for that was I was ashamed of it. I was ashamed. I knew better, right? I knew that smoking was really harmful for my body, and at the same time, I couldn't necessarily or didn't hadn't yet found the tools to volitionally change that behavior. So for my partner at the time, my partner's 60th birthday, that was my present to her, as I quit smoking. Um, I did use Chantix, which is a medication that often is used to help with the process of smoking cessation. And the mechanism of action for Chantix is that it blocks the dopamine receptors, and so you don't get that feel good experience from the nicotine. And so it thankfully worked for me. It took me. I had one false start. I used Chantix, quit for a little while, and then had a fairly significant stressor and had a relapse, started smoking again, and then second time around it did work for me. I will always be a smoker. I just don't always smoke. And so I think that the point number one here, don't assume clients will be honest with you. I think there's a lot of truth there, and I think that we need to recognize that and realize that that's okay. The fact that the client is disclosing any drug use at all is a sign that there's a level of safety and attachment in the relationship. So all that. Now the second point here, clients are going to use despite consequences. I think this is another really important thing for us to realize, both with clinical mental health. In clinical mental health settings and also in school counseling settings, is oftentimes people don't wake up and hope to be addicted to a drug. This is not what people are necessarily after. We don't aspire to be drug addicts. And I think what happens, and I've got a few videos in your show this week from Dr. Gabor Mate, who I have a great amount of respect for with regard to his approach to conceptualizing addiction. And what we know from the research and from Dr. Mate's work in harm reduction, we know that consequences are not enough to change behaviors. And so you see people that kind of go sort of shotgun down the avalanche, to borrow a line from John Colvin, towards this sort of bottom, right? People will continue to use even though there is loss associated with that. Probably one of the more current approaches to working with people that have substance use disorders is motivational interviewing. And if you've not yet had your theories class or those sorts of things, this is an important theory for us all to pay attention to. And I think that if you look deeply into the motivational interviewing process, there's a whole lot that's really reflective of person-centered approaches. And so when I think about this in the sort of scheme of substance use treatment, it makes sense, because what we know is that substances replace connection. Addiction, I think it's Dr. Mate that says addiction is the opposite of connection. Whenever I don't have that from my naturally occurring endogenous reward systems, then I'm going to go look for it. And when I find it in cocaine, then guess what? I'm going to keep going after it. And so this is in contrast to some of the older approaches of treatment, which had to do with more of a sort of a moralistic approach with regard to encouraging the client or the student to confront their denial. Um, Sometimes if a person is in active substance use treatment, again, this is maybe not our scope if we're only working as clinical or school counselors. We're not specializing in substance use counseling. But oftentimes you'll have clients that have to um, consent to regular urinalysis if there's more severe substance use issues going on. Okay, let's see. So in addition to substances, that craving for dopamine can happen with any behavior. Gambling is another pretty common example, at least sort of diagnostically. But you can think about people can be addicted to running. People can be addicted to TV. People could be addicted to food. People can be addicted to sleep. People can be addicted to a lot of things. And so I think it's important to remember that the process and what's happening in the brain is really important for us to sort of hold as primary. And it's not as much about the particular behavior as it is about the reward system. And so gambling disorder, to come back to this slide, gambling disorder is another fairly common one that you'll see sort of in the field of mental health, and you can see here what the different sort of criteria are for diagnostics stuff. Again, I'm not going to spend a lot of time there. I think the treatment planning um, aspect of for gambling disorder is also interesting. I think there's what the literature shows is there's no real proven way to prevent a gambling disorder, but that we can target individuals and groups at risk with psychoeducation and things like that. You might often see interventions or treatment strategies that are sort of based in CBT, behavior therapy specifically, and then also in family systems work.